Chapter 8, Dissociative Disorders and Somatic Symptom-Related Disorders. The Kring et al. Text covers these two types of disorders together because they share commonalities, including the fact that both are thought to be associated with stressful experiences, and the symptoms of both disorders do not involve the direct expression of anxiety. Also, these two types of disorders tend to be comorbid. The DSM-5 contains three major dissociative disorders: dissociative amnesia, depersonalization derealization disorder, and dissociative identity disorder, formerly known as multiple personality disorder. The dissociative disorders are all presumed to be caused by a common mechanism, dissociation, which results in some aspects of cognition or experience being inaccessible consciously. In other words, dissociation involves the failure of consciousness to perform its usual role of integrating our cognitions, emotions, motivations, and other aspects of experience in our awareness. Some mild dissociative states are common, for example, missing a turn on the road home when thinking about problems. Dissociative disorders are thought to result from extremely high levels of dissociation. Psychodynamic and behavior theorists consider pathological dissociation to be an avoidance response that protects the person from consciously experiencing stressful events. This slide contains a brief description of each type of disorder. Few high-quality studies have been done with regard to the prevalence of dissociative disorders. This slide provides the best estimates available to date. Note that both of these studies are quite dated. Dissociative disorders raise fundamental questions about how memory works under stress. Psychodynamic theorists suggest that in dissociative disorders, traumatic memories are repressed as they are so aversive. Cognitive theorists question how this could happen, as research shows that extreme stress usually enhances rather than impairs memory. The nature of memory does change under stress. Under extreme stress, memory for emotionally relevant stimuli is enhanced, while memory for neutral stimuli is impaired. People under stress tend to focus on the central features of the threatening situation and ignore peripheral features. So how are dissociative disorders explained then? One explanation may be that dissociative disorders involve unusual ways of responding to stress. For example, extremely high levels of stress hormones could interfere with memory formation. The person with dissociative amnesia is unable to recall personal information, usually information about some traumatic experience. The holes in memory are too extensive to be explained by ordinary forgetfulness. The information is not permanently lost, but it cannot be retrieved during the episode of amnesia, which may last for as short a period as several hours or as long as several years. The amnesia usually disappears as suddenly as it begins, with complete recovery and only a small chance of recurrence. For the fugue subtype, memory loss is more extensive. This slide contains the DSM-5 criteria for dissociative amnesia supplied in the Kring et al. Text. In depersonalization derealization disorder, the person's perception of the self or surroundings is disconcertingly and disruptively altered. The altered perceptions are usually triggered by stress. There is no disturbance in memory involved in this disorder. In depersonalization episodes, people rather suddenly lose their sense of self. This involves unusual sensory experiences. For example, their limbs may feel drastically changed in size, or their voices may sound strange to them. They may have the impression that they are outside their bodies, viewing themselves from a distance. Sometimes they feel mechanical, as though they and others are robots. Derealization refers to the sensation that the world has become unreal. Depersonalization derealization disorder usually begins in adolescence and can have an abrupt or insidious or gradual onset. Once it begins, its course is chronic. It is commonly comorbid with personality disorders, depression, and anxiety disorders. This slide displays the DSM-5 criteria for dissociative identity disorder, otherwise referred to as DID. In order to receive a diagnosis of DID, The DSM-5 requires that a person have at least 2 separate personalities, also called alters. The diagnosis also requires that the existence of different alters be chronic. DID usually begins in childhood, but it is rarely diagnosed until adulthood. DID is more severe and extensive than the other dissociative disorders, and recovery can be less complete. Diagnoses that are often present with DID include PTSD, MDD, and somatic symptom disorders. DID is commonly accompanied by other symptoms such as headaches, hallucinations, suicide attempts, and self-injurious behavior, as well as by other dissociative symptoms such as amnesia and depersonalization. Although commonly confused with schizophrenia, people with DID do not show the thought disorder and behavioral disorganization characteristic of schizophrenia. Almost all patients diagnosed with DID report severe childhood abuse. There are 2 major theories of DID, the post-traumatic model and the sociocognitive model. Both theories actually suggest that severe physical or sexual abuse during childhood set the stage for DID. The post-traumatic model proposes that some people are particularly likely to use dissociation to cope with trauma, and this is seen as the key factor in causing people to develop alters after trauma. The sociocognitive theory considers DID to be the result of learning to enact social roles. According to this model, alters appear in response to suggestions by therapists, exposure to media reports of DID, or other cultural influences. An important implication of this model is that DID could be created in therapy. However, this is not to imply that it is not real. These 2 models are merely 2 different views of how DID develops. The Kring et al. Text discusses the fact that DID is a particularly debated disorder. Some of the criticisms of DID discussed in the text include those listed on this slide. The goals of treatment for DID include using an empathic and gentle stance to help the client to function as one wholly integrated person, convince the person that splitting into different personalities is no longer necessary to deal with traumas, and help teach the person more effective ways to cope with stress. People with DID are often hospitalized to avoid self-harm and to begin the treatment in a more intensive fashion. Psychodynamic approaches involve hypnosis in order to access repressed memories, but this approach may actually worsen DID symptoms. This slide contains links to YouTube videos of Herschel Walker, a famous football player diagnosed with DID. Somatic symptom and related disorders are defined by excessive concerns about physical symptoms of health. The DSM-4-TR required that these symptoms be unexplained medically. However, the DSM-5 removed this requirement. The DSM-5 includes 3 major somatic symptom and related disorders: somatic symptom disorder, illness anxiety disorder, and conversion disorder. Somatic symptom disorder involves major distress or energy expended regarding a somatic symptom or symptoms. Illness anxiety disorder involves fears about having a major medical illness in the absence of somatic symptoms. Conversion disorder involves neurobiological symptoms that are not medically explained. People with somatic symptom and related disorders tend to seek frequent medical treatment, sometimes at great expense. They often see many different doctors and try many different kinds of medication for a given medical concern. Hospitalization and even surgery are common. People with somatic symptom and related disorders are often dissatisfied with medical care, and many become unable to work. There is incredible diversity among people diagnosed with these disorders, and some people develop these somatic symptoms in the context of anxiety and depressive disorders, while others do not. It is also questioned how we determine how much anxiety constitutes excessive anxiety over one's health. Calling one's symptoms into question has also been considered to be stigmatizing. Because these disorders are so newly defined, there's not a lot of epidemiological evidence about the specific disorders. What we know from the DSM-4 TR is that these disorders tend to develop in early adulthood. Although many will experience these concerns throughout their life, the symptoms will wax and wane. Somatic symptom-related disorders tend to be comorbid with anxiety disorders, mood disorders, substance use disorders, and personality disorders. This slide contains the DSM-5 criteria for somatic symptom disorder. These 3 core criteria are: 1, the person must experience at least one somatic symptom that is distressing or disrupts daily life. 2, the person must experience excessive thoughts, feelings, and behaviors related to somatic symptoms or health concerns, as indicated by at least 2 of the following: health-related anxiety, disproportionate concerns about the medical seriousness of symptoms, and excessive time and energy devoted to health concerns. 3, the duration of these symptoms must be at least 6 months. This slide contains some interesting external resources related to somatic symptom disorder, as well as a thought question. This slide contains the DSM-5 criteria for illness anxiety disorder. The main feature of illness anxiety disorder is a preoccupation with fears of having a serious disease despite having no significant somatic symptoms. To meet DSM-5 criteria for this diagnosis, these fears must lead to excessive care-seeking or maladaptive avoidance behaviors that persist for at least 6 months. In conversion disorder, the person suddenly develops a neurological symptoms, such as blindness or paralysis. The symptoms suggest an illness related to neurological damage, but medical tests indicate that the bodily organs and nervous system are fine. This slide contains a link to a news story on conversion disorder. This slide contains 3 videos of presentations given by Dr. Jeffrey Staub, a psychiatrist at the Mayo Clinic. These disorders do not appear to be heritable. There are several proposed causes of these disorders. In terms of neurobiology, it may be that some people have hyperactive brain regions that are involved in evaluating the unpleasantness of body sensations. Cognitive behavioral models of these disorders focus on the mechanisms that can contribute to excessive focus on and anxiety over health concerns. Models of conversion disorder are fairly distinct from the models that have been developed for the other somatic symptom disorders. From a psychodynamic perspective, some perceptual abilities may occur outside consciousness. From this perspective, one way to understand conversion disorder is that there is a disruption in consciousness, such that a person fails to have explicit awareness of sensory and motor information. Another factor encompassed by psychodynamic explanations is motivation. Some people may be motivated to have a specific condition. One major obstacle to treatment is that most people with somatic symptom and related disorders do not want to consult with mental health professionals. Healthcare system interventions involve coaching medical doctors and their teams in providing care for people with somatic symptom disorders, and informing physicians when a patient appears to be an intensive user of healthcare services so that they can minimize the use of diagnostic tests and medications. There are no RCTs on the treatment of conversion disorder. In studies with no control group, psychoanalysis, psychodynamic psychotherapy, and hypnosis have not been demonstrated useful with conversion disorder. With regard to the other somatic disorders, studies with no control group indicate that psychodynamic treatment may be effective in alleviating the physical symptoms. CBT has also been used to treat these disorders. Behavioral techniques such as exposure and family interventions to reduce reinforcement of the sick role have also been used. It has also been found that antidepressants are likely to be helpful when pain is a dominant symptom.